This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
He is a 4-year-old child who has a developmental cataract, both eyes. This is the classical lamellar cataracts, what we see with the central disc opacity, and he is scheduled for surgery. So obviously we're going to undercorrect him by about 4.5 diopters, and these are his biometric reports, and he has got bilateral cataracts. Surgery is being done under IV sedation and a subtenance block. 2 side puts are made. The capsule is stained under the air bubble. Dispersive OD fills in the anterior chamber. 2.8 mm posterior limbal incision is created now. Time to perform the rhexis. The most important step during cataract surgery is to get the appropriately sized and centered anterior and posterior capsulorhexis. So that's the only slightly challenging part. The cataract surgery is actually very simple. So the capsule is punctured with a needle. I couldn't perforate with the forceps. The flap is held, and then I'm tearing it very slowly. I'm just trying to focus so that I get the appropriately sized rhexis. I would want to have a 5 mm rhexis in this patient. The rhexis is done. Very gentle hydrodissection just to loosen out the lens matter from the anterior capsule, and the equator is being done. So time to aspirate the soft lens matter. I'll be in the epinucleus mode itself. Soft lens matter gently nudged out of the bag and then emulsified in toto. So removing the lens matter is the easiest part of the surgery. We have got some cortex which is remaining, and gently the cortex is stripped. So in a couple of minutes actually the cataract surgery is over. So now is the time to perform the posterior capsulorhexis. I prefer to put in cohesive OVD, but not to overfill the chamber. The posterior capsule is then perforated with the bent cystitome. And once we see a small slit in the posterior capsule, that's the time when I go in and put in sodium hyaluronate a little bit between the opening so that it goes and settles itself in the burger space. I prefer to use the Dr. Haldipurkar forceps for posterior capsulorhexis as well. The chamber is maintained by the sodium hyaluronate. I am still going through the main incision. The capsule is held and gently torn in a circular fashion. Again, I want to size this in an appropriate way. The preferred sizing for me would be around 4 mm. That's what I'm aiming at now. During rhexis, I wouldn't want to disturb the hyaloid. So for that, we need to maintain the chamber, and the sodium hyaluronate which are used both in front and behind the posterior capsule is going to help us. So the posterior capsulorhexis is also done. Time to place in the lens. I want to place the lens before I consider whether I want to do vitrectomy or not. The distal haptics of the planned multipiece lens is gently negotiated over the posterior capsule and under the anterior capsule. The lens is then gently dialed, so now we have both the haptics inside the bag. I want to remove all the OVD both in front. At this stage, the anterior hyaloid is not yet disturbed, so I'm just thinking whether should I opt out. I'm trying to remove the OVD which is sticking to the posterior surface of the lens and also behind the lens. The irrigation bottle is kept very low. The OVD seems to be taken care of, and I am hydrating the wounds. This stage I just want to confirm any absence of any vitreous prolapse. There is some hint that I'm seeing few fibrils behind the lens, so I thought it would be better off to just go in and do a limited anterior vitrectomy. So with the irrigation in my left hand and the bottle light kept very low, I go in with my 23G cutter, lift the lens up, and then do the limited anterior vitrectomy. So usually it begins by placing the port cutter posteriorly and then gradually turn it sideways and then anteriorly. All the OVD which is sticking onto the posterior surface of the lens also is aspirated out. The lens is maneuvered so that the haptics are at 3 and 9 o'clock position. I am sitting superiorly because the patient had some withdrawal astigmatism. Triamcinolone acetate is used to reconfirm the absence of any vitreous prolapse. There seems to be none. So at this stage we can clearly see the defines of the anterior capsulorhexis and the posterior capsulorhexis. I'm using diluted pilocarpine to constrict the pupil. So the pupil has come down. I would like to suture the main wound. I have put in air bubble, and then I'm going to use tenovicryl to suture the 2.8 mm incision. the knot is buried. The idea of using the vicryl is that it gets absorbed, so you don't have to bother to remove, and that's it, the case is done. To summarize, for the beginner surgeon, doing a posterior capsulorhexis can be intimidating, but especially in the pediatric cataracts when the zonules are very healthy, it's not so difficult. The posterior capsule is slightly more thinner than the anterior capsule. You just have to get used to the consistency of the flap. And obviously in the pediatric patients, because the zonules are very healthy, the capsule is very elastic. The capsule always tends to tear it much more larger than what you intend to be. So because the capsule is elastic and there is always a risk of the rhexis turning out to be bigger than what we aim for, trying to use a combination of tearing predominantly and a little bit of shearing technique during both anterior and posterior capsulorhexis would ensure that we don't produce a bigger rhexis. So that was it. Thank you for watching and hope you found this helpful.